Hello, everybody. This is Rich Swelling.
This is Len Zwelling.
Hello, and we're here with another edition of Father-Son Talk. So, Dr. Leonard Zwelling, my father, you spent a year on Capitol Hill, correct?
I did.
Yes,
yes, I did.
And you were actually interested in affecting healthcare policy.
I was interested in doing that, yes.
And it didn't happen?
No, it didn't happen.
Why not?
The Congress doesn't work that way.
Okay.
I mean, the mechanisms by which laws are made really aren't affected very much by the people that are often affected by the laws, unfortunately.
Yeah. Well, I mean, I'm curious in regards, the reason why we're here to talk today is about the recent vote in the House.
Yes.
Narrowly passed to
one
AHCA.
vote.
Yeah, one vote, but 20 Republican dissents and 3 abstentions. And so I guess the question is, where does it go from here? And I guess tie it into what you learned from, when you spent time in Capitol Hill, and you were there as Obamacare was about to kick into high gear.
Right, and a lot of the things that were going on around Obamacare are going on here. This bill now has to move to the Senate. And the Senate has a different set of rules with regard to how it passes the bills. If a bill will be a net negative to the budget, in other words, it will spend less money, it'll save money, it is possible to use a mechanism called reconciliation to pass that bill, in which case there can be no filibuster, which is a blocking of the legislation by the minority party. And there'll be a few amendments, relatively small amount of discussion, and it will take just 51 votes to pass the bill. If and only if the bill is judged by the parliamentarian as saving money and applies to the reconciliation process. Also, we have to wait for the Congressional Budget Office to score the bill to find out what they believe the effect on the economy will be, or the effect, more importantly, on people, health care, and the federal budget.
So let's back up a little bit, because I know that when the vote failed last time, a month or two ago.
Well, they didn't take the vote.
Right, but there was talk that this was just shelved and it wasn't going to come up again.
That's right.
So how did this come back? How did it come back?
In truth, or what they say? What they say.
I'm more interested in the truth.
Okay, what they basically say is that they threw about $8 billion more into the Medicaid pool, and that brought some people over. I think what really happened is the president twisted arms, and I think he was getting desperate to have some legislative victory and probably put the pressure on some members of the Republican caucus.
The Freedom Caucus, or
I think he made phone calls to everybody. I don't know, but I guess he called every Republican he could get who he could get on a speed dial.
So it came back up for a vote. What are the major changes, as you understand it, from the AHC as it was, the one that didn't even get to a vote?
The biggest changes, as I understand them, is there was more money put into the pool for people at high risk. They are allowing the states to opt out of specific aspects of Medicaid, and they're also allowing states to opt out of guaranteeing certain forms of health care. Remember, in Obamacare, every policy had to contain certain kinds of guarantees like maternity care and preventive care. And that ran the price up because it's more that has to be covered. So now the question is going to be, if you take those things out, will the prices drop? The answer is the prices probably will drop. The question is, what do you have left? I think what nobody really is certain of is what kinds of policies will really be out there. Will there be any use to people? Will they really cover any sickness? And I think people are just going to struggle because each state now is going to make its own rules.
And I know that that's a big concern for constituents, especially in a lot of the states that might be affected in that way. A lot of people are very scared that they're going to lose out on health coverage that they already have.
The biggest conflict here is probably in states that are more Republican than Democrat, what they call red states. Some of those red states decided to extend Medicaid as the Obamacare law wanted them to, and a vast majority of the money to extend Medicaid came from the federal government. So states like Texas didn't take advantage of that, and so its Medicaid population really didn't expand, and there are still a lot of people who are fairly poor who don't have access to Medicaid, where in a place like Ohio, which did extend Medicaid, they have captured many more people in their Medicaid rolls at the price to the federal government, not to Ohio. If that's reversed, there's two things that will happen. First off, the money from the federal government will not flow to Ohio anymore to cover those people. And if those people are going to remain covered as Ohio wants them to be, Ohio is going to have to come up with the money.
Yeah. Mm-hmm.
And I think that most states are already worried about the burden that Medicaid puts on their budgets. And for that to go up now, because there will be more people included in Medicaid, and a great percentage of the coverage for those people had come from the federal government, now it won't, that really puts a burden on the states.
Mm-hmm. And so as far as where the bill goes from here, and obviously now it goes to the Senate, but based on your experience, I mean, I'd love for you to tie it into your knowledge of working politics in Washington. You spent a year there, you saw kind of what goes on. So what do you see? I mean, I know that a few times when we talked about this before, you said it's just not certain yet what's going to happen in the Senate.
It's not. It's not certain at all. First off, the question of reconciliation has to be answered.
And this is a word that I've been heard, thrown around a lot, this whole reconciliation bill. And I mean, you seem to be saying that it's trying to be used to override or just completely preclude a possible filibuster.
It doesn't override. It just precludes the filibuster. There'll be no filibuster if the Republicans decide to try to pass this bill through reconciliation.
Right.
And if the parliamentarian and the Congressional Budget Office all agree that it can be passed through reconciliation, then undoubtedly it will be. If this bill is not passed through reconciliation, it will not be passed.
And by reconciliation, you mean it just they have to show that it would save the government money in some way?
Save the government money, and it'll take 51 votes. That's all it will take.
So, and that's what they need, because they can't get the 60.
They only have 52 right now.
Right.
And that presumes, which is a huge presumption, that all the Republicans vote for the bill, and there are many. Lisa Murkowski in Alaska, Susan Collins in Maine, Rob Portman in Ohio, Cory Gardner in Colorado, all in states who've expanded Medicaid and don't like this much at all.
Mm-hmm. And what about, like here in Texas, I mean, you were talking about Ted Cruz, who...
Well, Texas Cruz may not think it goes far enough.
Right.
He may want to eradicate any traces of Obamacare and any traces of the federal government helping people get their health insurance, and leave it all to the states. He wants just what he would probably favor is a big block grant of a ton of money coming into Texas back from the federal government, where Texas determines solely what happens to that money.
Mm-hmm. And again, that comes back to the issue of states and what each individual state does with it.
Yes, and this is a real question of whether the federal government is going, because to a large extent, this new bill takes a lot of the guarantees that were provided by the federal government through Obamacare and throws them out. Mm-hmm. And puts the responsibility, if there is any, for insuring people back on the states, mm-hmm. which is not a good bet in the sense you won't get any uniformity. Undoubtedly, there will be differences from states. Now, some people say that's good. We'll do 50 experiments, and the ones who are most successful, everybody else will copy. And that's a possibility. I mean, that could happen.
But meanwhile, there are a lot of people who are concerned that they're going to lose the benefits that they currently have under the ACA.
They will.
Yeah.
They will. Yeah. There will be no question that there will be people who... The other thing that's a big part of the new bill is the subsidies, which were cash payments to people who were who made enough so they wouldn't get Medicaid, but were 400% or lower above the poverty level. Those people were getting subsidies. Mm-hmm. They're getting help. Cash help from the federal government to buy their health insurance. That's going to be done away with, and we have tax credits instead, and the tax credits are different depending on how old you are. So,
well, this leads to the next question of what people are talking about, which is there was the big to do about the Democrats saying nah goodbye because to the Republicans, because under what the Democrats think is that the Republicans just gave up their seats for the 2018 election, and there are going to be a lot of constituents in those red districts who are poor who might be really angry about this vote.
Yeah, it's possible. I mean, a fair number of the Republican districts are safe because mm-hmm. of the way they've been gerrymandered.
Yeah, sure.
So it's not likely that those people will lose their seats. There, I believe, were 14 members of the Republican Party who came from districts that Hillary Clinton carried mm-hmm. who voted for the bill. And I guess those seats are in jeopardy. it will take more than 14 seats for the Democrats to get the majority in the Senate, in the House. Anyway.
And I guess what my question was is that if those Republicans knew that this was a possible political jeopardizer, voting for this bill, but they did so anyway, were they kind of stuck between a rock and a hard place and saying, okay, well, we promised constituents this. They might vote us out, but you know what? We have to follow through on these promises. It's the lesser of
they're caught in the same vice that the Democrats were caught back in 2009, where they promised to do something with health care, were caught, did it, it got a bad name, the exchanges rolled out very poorly, and so by the time the 2012 election came around, or the 2010 election came around, and then 2012 also, the Democrats lost steam, and also there's the fact that usually the party that's out of the White House gains seats in the midterm elections anyway.
Right.
So I think that was... I think the country hasn't made up its mind, and I can't really blame the country for not making up its mind, because the discussion and the dialogue about health care has been so poor.
I mean, and this goes back to your classic statement again and again. I love the way you put this. The whole idea of, is healthcare Gucci slippers, or is it like the fire department?
Yeah,
is it a public good, or is it a private?
Yeah, is it a privilege, or is it a right? I think we haven't had that discussion yet. And the current battle between Obamacare and the new plan, in both cases, healthcare is not a right. It is more of a right under Obamacare, because more people have access to insurance under Obamacare than had access to insurance before Obamacare. Under the new plan, fewer people will have access to insurance under the new health care bill than would be the case under Obamacare. So, and there's also a tremendous wealth transfer in this bill, because a lot of the taxes that were applied to the wealthy are being eradicated in the new bill. So there's a tremendous transfer of wealth from the poor to the rich in the new bill, which means it's really, frankly, not a very fair bill, and certainly not a progressive bill.
Well, and that, again, leads to, I think, that the next discussion, which is what's going to happen, we don't know in 2018 as far as who gets elected, but if presumably the party that you said is out of power gets reinstated, if somehow the Democrats manage to get back their majorities in the House and the Senate, which is, a tough ask right now, but if they did, I mean, I was actually listening to, I forgot who it was, somebody on Fox News was saying that they think that, in a matter of 7 or 8 years, we're going to be at single payer. It's just going to happen.
We're going to be at single payer anyway. I don't know. I can't put a time frame on it. It could be 20 years. But the economics of healthcare, forget about the politics from them.
Sure. I mean,
the economics of healthcare are that the only way to absorb this tremendous cost, tremendous burden on society, is to distribute the cost of this throughout the society. Just like we do with the police, just like we do with the fire department. Everybody pays their taxes, and everybody has got a fire department, and everybody has police, and everybody's got the army. This has to be viewed, I think, at some point as a right of being an American. And it will get there. There's no question that there are many forces going on, artificial intelligence, making diagnostics more available to more people. So it's inevitable that we're going to get to a single-payer system. The question is, will all these political maneuverings hasten it or slow it down? I think Obamacare slowed it down.
Really? You think it slowed it down?
It did. I think it slowed it down because more people got access to insurance in the more conventional sense. So there wasn't quite the push necessary to move to a basically public option.
I see. So you say it took the private healthcare industry to shift money.
You will hear now a lot of talk about the public option from the left. They're going to put that's the pressure they will put on the Senate bill. I don't think it'll make it. I don't think it didn't make it last time when the argument came up in the Health, Education, Labor, and Pensions Committee to put a public option in Obamacare. A public option would basically be Medicare for everyone.
Right, which is what, I mean...
So if you got the public option in there, then you've really taken a huge step toward a single-payer system. But so far, that's been kept out. If that is... And I can't imagine that getting back in. Not
now.
No.
I mean...
No. But I think you'll hear it again. I think the Democrats, particularly people like Elizabeth Warren and Bernie Sanders, will bring up the public option as a better approach. What they're going to have to come up with, basically, if they're not going to vote for the Republican plan, and clearly they won't, they're not going to get the option to vote for Obamacare. Mm-hmm. They're going to have to vote for something like Obamacare that's different from Obamacare. And the biggest step they could take in their direction in that case would be to have a public option.
Sure, yeah. Now this gets into, I mean, we talked a little bit about this before, but your own personal view on this, which is, I mean, as I understand it, right, you've been for single payer for a long time. Personally.
Yeah, I mean, I just think that you have to distribute the risk of the cost of health care, which is in excess of $3 trillion right now, throughout the population. So if you're going to have what people call insurance, mm-hmm. then everybody should be in the pool because everybody's at risk for something. It's not like car insurance where lousy drivers ought to pay more.
Sure.
If you've had more accidents, you ought to pay more.
But if you're born with genetically predisposed to a certain condition, that's not your fault. It's not
everybody's genetically predisposed to a different condition.
Right.
It's called death. Everybody's going to die. Everybody's going to get sick. So it's sort of preposterous to think that somehow there's a way you can get out of this.
Right.
You can't get out of it.
Which is my personal argument for, I mean, I just think that, I mean, my personal take on this, I say as I get a little bit older, it's funny, like, you know, the stereotype is supposed to be that you go more conservative as you get older. I find myself going more and more left in the sense that just the monetization of human life, the monetization of human health seems like an inherently morally evil idea.
Yeah,
I don't
really think that's what this is about. This is about people making money, and there are different aspects of the healthcare industrial complex, each wanting to make more and more money, whether it's the hospitals or the doctors.
Right, but the fact that, you know, people's health and people's livelihoods are reduced to a dollar figure, that's what I'm saying. The fact that it's done that way at all.
Well, it has to be. People make their livelihoods in the healthcare industry. Everybody wants to be paid.
But instead of, you know, having a single payer system where there's an understanding, like the police, like the fire department, saying, okay, well, we all have made a tacit agreement as a society that this is something that we collectively pay for, whether it's through taxes or whatever, because it's, you know, I mean, I don't want to use the word obligated because that's a loaded word, but I mean, we just make an agreement that it's worth it because collectively as a society we function better when these certain things are taken care of that we can't control that. I mean,
the society is probably better off. I mean,
yes.
We're better off if we're healthier. And if there's a way to make us healthier, then we ought to be pursuing that. And I think the way to do that is through education of health.
Sure.
Not just picking away at disease, which is sort of the system we have now. We really don't have a healthcare system. We have a disease care system, and we ought to have a healthcare system. That would be novel.
And so, as distinguished, so disease care isn't just treating existing sickness versus healthcare, or what's the distinction?
You don't do any health maintenance. I mean, I think that was the idea of having preventive care in Obamacare. Things like mammograms and colonoscopies were all paid for 100% in Obamacare. And that's currently the law of the land now. So if you have an insurance policy, you're going, but you can get mammograms, and it shouldn't cost you anything.
Preventative care, sure.
Yeah, so it's the idea of preventing disease, and that could go through diet, the lack of smoking cessation. Mm-hmm. All those things are beneficial to the health of the country and to the individual, for that matter.
But it seems the big ideological push against something like single payer is this idea that, you know, people are going to get something that they don't, quote unquote, don't deserve. That, you know, I am paying, like there was that, I forgot which senator it was basically in response to Jimmy Kimmel's monologue. He basically says, sorry, your sob story doesn't entitle me, or doesn't mean that I'm, you know, have to pay for your kid's health care. And
yeah, that's an individualistic approach to health care. It's not the one I have, but it's the one that people, I think that because health care is likely to be needed by everybody at some time, it has a more communitarian value. And so everybody ought to share in its cost, and everybody will share in its benefits. The idea of personalizing the way we pay for health care. We should personalize the health care, but not the way we pay for it.
Right. And that's the problem, is the ideological push seems to be that, you know, I don't want to pay for somebody else's health care because they don't deserve my...
Well, the one that people point out all the time is that why would a single man at the age of 55 have to buy a policy that includes maternity care?
Mm-hmm.
And the answer is the distribution of risk throughout the country ought to be widespread.
Right, but that presumes, of course, that you're operating from a communitarian approach, and a lot of people are operating from, no, it's me, I'm out for me. And
well, America has this duality of the individual, the John Wayne sort of thing, and a communitarian approach, where we were as a country. So we will fight World War II as a country, but we always like the hero to act as the individual. And John Wayne would be the person.
Yeah.
So the question is, where do we come down in healthcare? And I just don't think we've decided yet.
We haven't. Yeah, the basic philosophical discussion about the right versus privilege. Now, how that gets resolved, I don't know. And so what you seem to be saying before is you're just not sure it'll happen, but you're just not sure when.
Yeah, it depends when we get to the inflection point in the economy, where the cost of healthcare has gotten so high,
mm-hmm.
and the number of people who don't have access to healthcare has gotten also sufficiently high. Mm-hmm. For example, this bill that the Republicans passed will make that higher. The Congressional Budget Office said 24 million people will lose insurance who currently have it. So more people will be uninsured. More people will have difficulty getting access to health care. As that gets high enough so that the demand for health care is great enough in the politics are such that it will push over, it will tilt over.
Well, yeah, and it's not just the economics, but I mean, I was actually talking to somebody yesterday who went to, her congressman's office and said, it was Republican congressman here in the Houston area, voted for the bill, obviously, and she said, look, I have stage 4 cancer. I got bills that are in excess of $400,000 for just 2 months worth of drugs. And thankfully she had good insurance, but the fact remains it's like this bill, $400,000. And she's like, I don't know if I'm going to live much longer, and meanwhile I'm burdened with all these costs, and I don't know how this bill is going to affect what I have to pay. Am I going to suddenly have to, are we going to be out on the street? And there are a lot of people who are really concerned and really angry about this, and I'm wondering if the political side will, it can't just be about the economics.
I think it is just about the economics. I think the economics will translate into the political, as they often do. But I think it is about the economics. I think the cost of health care is soaring for a host of reasons: the aging population, the increased cost of technology, the increased cost of drugs, the fact that doctors don't want to make less money, yet things are more complicated and they're being paid less per unit of work. There are a whole host of factors going into that are all economic. Mm-hmm. They're hard economic realities. And I think those are the things that are going to really tip over into the political.
Now, the cost of drugs and the cost of treatment in this country, isn't it so much higher than in most parts of the world? I talked to people who...
Well, that's because it can be. There's no government control on drug prices.
Right.
In most of the European countries, there's control on the prices of everything involving healthcare. Mm-hmm. The services, the doctors, the hospitals, the drugs, everything is controlled to some extent. People are making a profit. They're not going broke, but they're also not making scads and scads of money. Some of these pharmaceutical industry companies are making tremendous profits.
Right. And that's part of the problem too. But there's no way to regulate them right now.
Sure.
There is?
Of course there is. You regulate them. You say, no, you can't make that kind of gouging.
But you got to get there, though. Who's going to pass that?
Well, you've got to have a system of which the drugs are part mm-hmm. that in total regulates the cost of healthcare and the prices of healthcare and the amount of money people make, not because there's anything wrong with making money, but mostly because it is a utility. Keeping people healthy is good for the country. Doing it at a reasonable cost and at a reasonable price, and they're not the same, mm-hmm. is a good idea. If the economics precludes that, which is the case now, the economics are such that people can make scads and scads of money, mm-hmm. then the government sometimes steps in. The counter-argument is to establish some form of competition. The problem with competition is competition is usually done between the demanders and the suppliers. In healthcare, a supplier is usually called a doctor, and a demander is usually called a patient. But the market in healthcare, what market there is usually made between payers and insurance companies. Mm-hmm. And so the actual suppliers and the actual demanders are not making the price, are not setting the benchmark price. So healthcare is an exception to normal economics.
Sounds complicated.
It is complicated, mm-hmm. as the president found out. He thought it was going to be easy, obviously, but it turns out it's not.
I didn't know it would be this hard.
That's right. It is hard. It's very complicated. And mm-hmm. the real reason it's complicated is lots of people are making lots of money in this business, and none of them want to make less. Mm-hmm. And that's really the...
That's circling back to what I was saying about the idea of just the monetization of human life and human health, which is, or the fact that it could be, I know you said it has to be at some level, but the fact that it's privatized, that, private entities can make money off of people's sickness. And
it's very privatized right now. Yeah. The question is, and the objection the Republicans have is they believe it ought to be more privatized. There would be more individual choice, more competition among insurance companies, not less.
And I get the sense you don't think that would solve the problem.
Well, it would solve the problem for the wealthy. It's like anything else. If you have the money, mm-hmm. a free market economy is great. If you have unlimited funds or a lot of money, the housing market, the car market, the clothing market, the jewelry market is fine with you. You can just keep buying what you want. But if you are not, if you're constrained, as most Americans are, then there's a lot they can't have. Now, that they can't have jewelry and they can't have expensive cars and they can't have big houses is not lethal. If you can't have health care, that can be lethal. Mm-hmm. And so the question is, should health care be put into the same economic category as goods like jewelry and houses and cars? And my answer is I don't think it should be. But other people think it ought to be. It's just a difference of opinion.
Now, do you think that that general attitude that it should be in the privilege category has been kind of inculcated in us over decades just by being the way things are?
The biggest problem started in World War II when people started to get health care benefits through their employers. Yeah. And people started to you displaced the cost of health care. Now, in the 40s, there was so little that medicine could do, and it was so relatively cheap that it didn't matter. Now, health care is incredibly expensive, and the competition issue is completely out of whack. It's just not. It's not what health care ought to be. It's gotten a lot more. It's gotten a lot more complicated, and a lot more expensive.
Now, when you say expensive, though, like actually expensive, or it's priced that way? We were talking about.
No. It's. You can do things. You couldn't do an MRI. You couldn't do a CAT scan. You couldn't do fancy blood work. You couldn't do certain surgery, high dose chemotherapy, bone marrow transplantation, heart transplantation, lung transplantation, liver transplantation. All these things were not. Nobody ever heard of these things in the 40s and 50s, mm-hmm. and now they're fairly routine, but they're also very pricey. Mm-hmm. No, they're really expensive. Healthcare is expensive.
Yeah.
It's not sort of expensive, it's very expensive.
So I guess to wrap this up, looking to the future, are you optimist, pessimist, some combination of the two as far as, if we can solve this problem or if there's going to be some kind of viable solution?
Oh, there's going to be a viable solution. We'll get a single-payer system because we have to. Mm-hmm. All the other countries in the world have already figured this out. Each of them have a different kinds of system, and no two countries are really identical. A couple of them are very similar, but even the European countries are all quite different in the exact way they deliver the health care. The only thing that's uniform is that they all have some sort of universal health care for their populations, and in most instances, the baseline level of care that everybody is provided is a nonprofit business.
Mm-hmm. So this would be, how is it? You can give the Reader's Digest version, but UK versus France versus Switzerland versus Scandinavia.
Well, it depends who owns the healthcare delivery, who pays for the healthcare delivery, is there an insurance product, So the case in Great Britain, it's completely socialized. Most people, there is a small private cash only sort of healthcare delivery, but the vast majority use the national health. In Canada, they're private docs, but the insurance is through the provinces. And in Germany, it's private insurance with private docs, but there's usually a cap on the amount of money the insurance costs for the basic insurance. And again, in many countries, like for example in Switzerland, you can buy a premium policy and get greater care, and maybe you don't wait as long. There's all kinds of ways this works, and there's no reason that the whole point of TRE's book, The Healing of America, is that we could learn from other people's experiences with healthcare delivery and pick the one that best fits us. What is the American solution to this? And we've just neglected that. We have done this mess.
Where you talked about the idea that we
except if you're over 65, then it's not a mess.
Then we have Then we have care for all when you're over 65. Yeah, that's why you said in your talks about this that we essentially have 4 systems, or like
we do have 4. We have 4 systems. So the 4th system is the one where there's no insurance whatsoever, and you're in sub-Saharan Africa with emergency rooms, which unfortunately somewhere between 15 and 20% of the population still struggle with. And that's no good, and that's not good medicine. Forget about anything else. It's lousy medicine. You don't get good continuing care by using episodic crisis management.
And also, it decreases the quality of the doctor-patient relationship. That's something I've heard you talk about a lot.
Well, there is no doctor-patient relationship when if all your care comes from emergency rooms. There is, it's one doctor and then another doctor and then another doctor. There is no doctor-patient relationship. So that's what's needed.
Well, I guess that, instead of wrapping it up, I guess that leads to something else we could talk about is you and your fellow doctors who you've grown up with, who you've worked with for a long time. I mean, the way I've heard you tell it, there's been a lot of frustration as to them being able to do their basic jobs. Just to be doctors, to practice what you call the art of medicine,
Well, people in private practice still can. It is not as lucrative as it used to be because the amount of money the insurers are paying is under constant pressure to go down, and there's a lot of deals being made and who's in a network and who's not, and if you're in the network, how much you make. But for the most part, if you're in private practice, to some extent you can play. Of course, if you're in plastic surgery or psychiatry, you can because they're pretty much cash-only businesses. But for the majority of people like internists and general surgeons and pediatricians, there are constraints on exactly what you can do. You often have to have permission from the insurance company to do it, which is a pain in the neck. There are electronic medical records that have to be contended with. There are a lot of constraints on doctors that weren't there when I trained, for sure.
And you also said that you think that the oncoming possible artificial intelligence boom might actually help.
Well, sure. I mean, if you could feed a computer with a set of symptoms and signs and laboratory tests, and have the computer say, 1 million or 2 million people with similar signs and symptoms, this was the likely diagnosis. Here's how you rule it in or rule it out. That's a tremendous advantage. I mean, to have that at your fingertips as a physician would be a good thing, I think. I mean, it wouldn't threaten me.
So it's
like the computer thought of it before I did wouldn't make me feel bad. But the art of medicine, delivering the care, there's still going to be a lot of bad news that has to be delivered. There's still going to be handling of families and patients that require human touch. And so I don't think doctors will be less like doctors. I think there'll be the opportunity to be more like doctors and less like machines. If you have machines doing the machine work, some people feel threatened by it. I don't.
You don't?
No.
Yeah.
No, not at all.
In fact, you seem contrary. You seem like you think it actually will help.
Oh yeah. Well, I'm always a big believer in if there's a checklist that you can go through to make sure you gather the right information and an algorithm that will analyze that information in such a fashion as to make the most likely diagnosis available to the doctor. That can't be a bad thing. That's got to be good.
So that's the optimistic part I think we can end on, right?
Yep.
A little bit good. So
very optimistic.
Thank you for your time, and we'll talk more, hopefully, when we know more about what the Senate's going
to do.
Bye-bye. See you later.
See you when the Senate decides.
Yeah, exactly.
Could be a year.
Who knows?